One has melanoma?
I've had two.
Are they all living? No one had bad metastases? I remember in internal medicine, I had a patient, she was only like mid-30s, but her husband died from melanoma. He'd had, I think, a lesion on his thigh, I think what it was, and it metastasizing, and he ended up dying. I mean, so how do you console a 35-year-old widow? You know, it's really hard.
There's a famous basketball lady from Kansas, and she has it in her eye.
Oh, speaking of, there's tons in Arkansas, Alabama. Have you guys heard that? There's I think 4 women who, 2 of them attended the same university, 2 in the same state. They all knew each other, and they all had ocular melanoma, which is very rare in and of itself. And then they come to find out they were reaching out on Facebook, and there was 30-something people now in that area that have had ocular melanoma, which is rare. But I was like, holy cow, I'm not going to the University of Alabama. I'm going to tell Dr. Britton, you better watch your eyeballs. But I think they're now doing a study, the epidemiology out there in that region as far as why are these people getting ocular melanoma. Did she survive, or did she have her eye taken out?
She's getting radiation now, but it's brand new.
Wow.
I don't know, Kathleen, do you know Jackie Stiles? Yeah, you know Jackie Stiles, who has ocular melanoma.
That's what I'm telling you.
Right now.
Cancers don't care, unfortunately. When, like I said, in head and neck, we had one lady, she was a young athlete, ran marathons. She ended up having a lesion on her tongue, and she'd had it removed, half of her tongue taken out, her lymph nodes. She was fine for about a year, and it came back in her lungs, and then she died a year after. Yes?
My mom's boss currently has melanoma in his lungs and in his legs, but he had I guess he had a melanoma back 90s. He was a Green Beret in Vietnam, and so I think it may have come from.
Yeah,
it just popped up all of a sudden.
That's what I'm telling you. You can lay dormant forever and just all of a sudden decide it's going to come back in a different spot. But melanoma, like I said, likes to go to the liver, lungs, and then the brain too. Okay. So melanoma, and hence its name, is a cancer arising from the melanocytes, which produces melanin or pigment in our skin. So it's the most serious type of skin cancers. These tend to metastasize, and they have a higher death rate. They can occur anywhere in the skin, mucosal membranes, GI, lymph nodes. And with melanoma, when you are staging it and you worry about melanomas, how aggressive it is, again, it's the depth of invasion with melanomas. So, and we talk about later, the scoring is using the Breslow depth of invasion, Breslow depth. So it just tells you how common melanoma is and how many people die from it. So that's a big number, 97,000 deaths in 2017. Median age 62 for men, younger in women. Most of these individuals are 20 to 40 year olds. So you have a lot of younger people that get melanoma. Male to female ratio, I would have 1.5, okay, 1.5 to 1. So again, still more common in men. Highest incidence in Caucasians, 20% in African Americans. So again, DNA damage by sun exposure. Usually it's confined to the dermis, but then it grows, and it's, like I said, it grows deeper down. Melanomas may look scary and maybe small, but you worry about how deep it is into the skin. Genetics, so genetic factors. You have a family member, I guess more of a first generation family member that has it, you have a higher risk of getting it. So then these are other genetic mutations that can arise as well. Just know that if your family member of yours has it, you have a higher risk of getting it. So it's my husband. My father-in-law, again, man who's played golf most of his life, You know, they don't look at the back of their ears, back of their head, back of their necks. And I guess he'd gone and got his hair cut one day, and the hairdresser noticed something on his ear. And he didn't think about it till he was at work, and another lady mentioned something on the back of his ear. Finally, he went to the doctor, and he had a biopsy, and it was a melanoma. And then, my stubborn father-in-law that he is, waited 6 weeks before he had it taken off. He was going surgeon shopping because he was worried about them having to take off his ear, you know, how much of a bad defect would he have. And, you know, I think, again, people don't realize melanoma can kill. And I don't think he took it as serious, you know, as he should have. Because by the time he had it taken off, and that surgeon who did it, I think it was an ENT, like, chastised him for waiting so long, you know, to get it removed. But now he has a defect, and he ended up going, he went to an ENT, ENT sent him to a surgeon, he ended up shopping, found a Mohs surgeon who removed it, and so he only has like a section of his ear off like that. For me, I would like take my whole ear off. I don't need it. Well, I have one there, but it's amazing. Have you ever seen anybody who's had their ear taken off, and it's left with just like a hole? It's really amazing looking. We can still hear, because we don't need this part. But his EAC was still there. Now sometimes people who have really bad cancers, we've had him take off, and we took out their ear and it was deeper in, so part of their canal's gone, so he basically has a giant flap that covers his whole side of his ear, so he didn't have an ear left at all. But he had it taken off. I don't know if he goes back and gets it checked regularly like he's supposed to. So I worry about it being right there by his ear, because what's close to your ear? Your brain. So I worry about him getting mets into his brain from the small little lines. Again, risk factors, sun exposure, genetic predisposition. History of greater than 5 sunburns during your lifetime doubles your risk. So when you're young, all those kids that get severe sunburns, you know, your children, that's why you gotta lather them up, or nieces and nephews. But think about us. How many severe sunburns have you had in your lifetime? I'm pretty sure I've ever had more than 5. So that's doubling my risk of getting a melanoma. And if you had previous dysplastic nevi, that also, I think, I can't remember, does it say here, or maybe I say it later, how many you have, any abnormal nevis. Because a lot of times if you have a funny looking mole and take it off, most likely it'll be dysplastic. It just means it's a funny looking mole. But if you have several of those funny looking moles, you have a higher risk of getting a melanoma. Again, fair complexion, blue eyes, blonde hair. So my father-in-law has blue eyes. His hair is white now, but he's very fair skinned. And then highest predictor of risk is if you're a very moly person. But then there's also I've also heard that if you don't have as many moles and you all of a sudden get a new dark mole, you have a higher risk of that being a melanoma than not. Again, more risk factors. Here it is. Tanning bed use, 75% increased risk is first exposure before the age of 35. That's all of us. All of us. And there was one young girl, I remember, I think she was started tanning at 16, and then by the time she was 24, she had a melanoma on her chin, on her lower leg. And, I mean, it was a giant defect that was taken out of her leg. And I want to say, I thought maybe she had might have had like groin metastases. I don't remember for sure, but I'm like 24, and you have a giant section of your leg taken out from a melanoma. Other skin cancers, so if you have a basal cell or squamous cell, you have a higher risk of getting a melanoma. There's the blistering sunburns in childhood. So a lot of times if people come in for skin lesions, you need to ask these questions. You know, how many have you had major sunburns? Have you had any other skin cancers? Did you use tanning beds when you were younger? If it was a female, most likely they said yes. So melanoma. So all of these have all subsets, which, you know, with the melanomas and the BCCs and the SCCs, I want you to be able to recognize the difference between all of the subsets. Okay. Melanoma, superficial spreading is the most common one that you will see. Next is the nodular, and then lentigo maligna, and then amelanotic melanomas. Those are the really scary ones, because those are the ones that are flesh colored, that don't look like anything, but out of your, for some reason, you're like, oh, maybe I should biopsy. And then it comes back as an amelanotic melanoma. And then acral melanomas, subungual, and I kind of talk about these later when we get down there, and then desmoplastic melanomas. So signs and symptoms of a melanoma. Why would you worry about anyone that comes in, what would they come in complaining of? Most likely they'll come in complaining of either I have this new mole, it's getting bigger, or they'll come in and say, I've had this mole for a long, long time, and all of a sudden it's starting to get bigger, it's starting to change. It kind of bleeds a little bit. It's changing colors. It's getting, one part of it's kind of dark, one part of it's kind of light. So someone comes in complaining of a changing mole or a new mole that is getting bigger, you think about a melanoma. One of my, well, she wasn't a classmate of mine. I think she was 2 years behind me. She got pregnant. So, you know, pregnancy jacks everything up. She had a new mole after she delivered a baby. She went to her primary care and they're like, oh, I'm sure it's just nothing. Well, she started watching it and it started to grow. And she went to a dermatologist to biopsy. It was a melanoma. So, you know, I think it was either a new mole or it was a mole that she's had that changed. So with pregnancy, it changes the hormones, everything. It wreaks havoc on your body. And that's one thing is being pregnant, it can change your moles. And so if you have or someone that's postpartum comes in complaining of a mole change, melanoma should be on your differential, higher on your differential. Again, history of melanomas, sunbathing, tanning, so those are the things that you should ask them about. And you guys already got the ABCDs of melanoma, right? So you need to start memorizing this, and then you should also start utilizing it. When you start seeing patients in the clinic, when you're out in practice that come in, and you can tell that they are somebody who likes to sunbathe. You know, you'll have those that you're like, okay, you're way too many shades dark and it's winter. You need to tell them stop getting in the tanning beds, and then also watch for these things in your moles. I don't have asymmetry with a V behind it. Okay, so again, physical exam, you would look at a mole, you want to put your hands on that mole, touch it, look at it, see if it bleeds. Here's in Caucasians primarily on the back, lower legs, African Americans, hand, feet, and nails. So that's where more commonly, so especially if you have an African American male come in, or patient come in complaining of a black spot on their nail that keeps getting bigger. You need to think about those things. They include mucosal surfaces, so nasopharynx. So we had several mucosal melanomas, which I'm sure I talked about back in head and neck, but we had an individual, he's an African American male that came in and he had these great sized lesions on the back of his throat that would just come popping up all the time, and we had to put him in surgery and remove them. High risk for melanoma, should have careful ocular exams to assess presence of melanoma in the iris and the retina. So again, someone comes in complaining about they've noticed a little dark spot in their eye, and that's not been there before. You need to really send them to see an ophthalmologist for them to take a close look at their eye. So there's a difference between benign, malignant. So you see that asymmetric border. You should, some of those junctional nevi. Did you guys talk about those? Mm-hmm. Kind of look like that one with the asymmetry, but they don't look as dark and scary looking as those. The border irregularity, and sometimes if they're skipping areas in the inside of them, they just look like not normal, right? That's why you have to be aware of your own moles. You know when something looks different and when it changes. So these are differential diagnoses. You can have dysplastic or blue nevi. Those are like little blue lakes, or we call them blue lakes. You see them on their lower lips and things like that. A pigmented AK, traumatic hematoma. So you can have, like, a lot of times you can get people who have even a bug bite that crust over and they pick at it, and then it gets hyperpigmented. So a lot of times people, like with my skin, you worry about hyperpigmentation that can look worrisome, but most of the times you think about your patient, look at him, well, most likely she has hyperpigmentation. Pigmented squamous cells, basal cells. Sometimes SKs can look like a melanoma, and any other nevi that sometimes change, but doesn't necessarily mean that they're melanoma. You should go ahead and biopsy those. So superficial spreading melanomas. Like I said, this is the most common type of melanoma. So these grow horizontally along the top layer of the skin. Again, it's the most common form that you'll see. But sometimes they don't look brown and dark like that. Sometimes they can have a purple hue to them as well. And these are the nodular melanomas. So these are faster growing, but it causes nearly half a melanoma-related deaths. So look at that. That was from January to March. Look how much that has changed, his mole. 2 months. It can look like a mole or bug bite or a pimple, but it's also often looks like a round black bump, just like that. These, however, don't fit the typical ABCDE, right? Because it doesn't look asymmetric. The borders are actually pretty normal. So these are a little bit more, it's kind of harder to diagnose just because they don't fit that ABCDE. If someone comes in complaining about it, but you need to look at the progression of their changing in size. So a lot of times in dermatology, people will take pictures, they measure, so you know that when he comes back, it has changed significantly. And these are usually men over the age of 50, although this guy looks pretty young. And then the lentigo malignas. So a question you were asking earlier about sunspots, those are solar lentigos. So sometimes solar lentigos and lentigo maligna kind of look the same. Except within this, you can see that darker patch within the solar lentigo that would make you more suspicious of it. But basically, when they go underneath the skin, they're called lentigo maligna melanoma. But usually surface-wise, you can just call them lentigo malignas. These are not very common. They're usually larger. So like this one's a pretty large, usually greater than 6 millimeters. So if you notice in dermatology, they measure in millimeters most of the times. 10 millimeters instead of saying, 1 centimeter, they say millimeters. I don't know why, but that's how they have always done it. And these boogers, amelanotic melanomas. So this is when the cells don't make melanin. And in these patients, they can be pink, they can be red, purple. A lot of times they're just flesh-colored lesions on the leg. And so when they're flesh-colored, they're harder to diagnose. And then you worry about, some people will say, oh, that's just a sebaceous gland, sebaceous hyperplasia. Or, oh, that's nothing, don't worry about it. So the delay in diagnosis is higher with amelanotic melanomas, even though they're rare. When I was on my derm rotation, Dr. Kester had said there was a patient that came in as a female. On her shin, she noticed a lesion, and he felt it and thought, oh, it's probably benign or maybe a BCC or something like that. But he went ahead and he decided to biopsy it, and it came back as an amelanotic melanoma. He just said something in his gut said I should just go ahead and biopsy it because it doesn't hurt. If you suspect anything and you're not sure, take a biopsy. It won't hurt the patient.
This is what one of mine was, and I had like 4 different doctors look at it over about 3 years because it was a really random, like pencil eraser sized kind of red bump. It didn't have like asymmetric borders or anything, and so they just said watch it, and then finally a dermatologist said that in like my age group there's a lot of people being diagnosed with melanoma, so she biopsied and it was stage 1.
In 3 years, it hadn't progressed, so I wonder.
No.
Huh.
Yeah.
So I didn't see anything about how fast they grow. But they say, though, with A melanosis, that means that that cell can't even do its normal function. It can't make melanin. So with amelanotic ones, they're generally more aggressive, just because they can't function they can't even do their normal thing they're supposed to do. Interesting. But that's good that it didn't grow.
Yeah.
Or didn't, invade.
Yeah.
Did you have to have 2?
I had a wide excision surgery.
So in melanoma, they usually have wider excisions depending upon the size of the initial lesion, but it's usually 1 centimeter margin. So think about it. If you have a lesion that's that small, 1 centimeter around is that big. You have a bigger defect with those.
It was like that much. Like I still have a scar.
So what if I wonder how big it got. How big did it get? Do you remember when she finally saw it?
Oh, just the mole
Uh-huh.
or the melanoma? It was still like a pencil eraser size.
Pencil erasers are how many millimeter? 5?
Yeah, maybe a little less, around there.
So those, I think it's greater than, I think I have it later, but greater than 6, I think, we have to have 2 centimeter margins.
Uh-huh.
Because the melanomas, like I said, like to have little fingers, you know. I told you guys about that one gentleman I saw that, in head neck, he had a melanoma right here at the crown of his head. He came in to see me, and it was probably like a 4 or 6 month follow-up. And he had a small little spot right up here, but it's a little dark black mole. It was firm, and you know, he don't have much skin or tissue on the scalp. And I took a biopsy of it, and it came back as a melanoma. I mean, it was a good, probably 4 centimeters away from his original lesion. So that tells you how far the little finger cells go out. So, that's scary though. You had 2 of them?
Yeah, I had one on my back. So she was a really great dermatologist in Austin, and she was like, well, obviously the one I was concerned about.
Did you have that one? Which one did you have first?
The one on my leg.
Okay.
And that's the one where they just watched and watched. And finally I was like, I just need to go have this biopsied. It was really bothering me. And then, so she went ahead and biopsied one on my back, which was, again, it wasn't like a typical melanoma. It was just darker than my other moles.
Mm-hmm.
And they were both melanomas.
Did you have a white excision on your back
Yes.
one too?
Like one, like 2 weeks after
Do
the
you have
other.
family history of melanoma?
I used to do tan and tanning beds all the time. So. Yep.
Now you have a higher risk of recurrences. You had 2 melanomas.
Uh-huh. So I've had like 10 other biopsies since
Uh-huh.
then. I go in every 4 months,
Okay.
and they've all been fine. But
And how long ago was this? Do you mind?
2015.
So you're right. You know, you're out of that 5-year window, but I think melanomas, I think they follow them for 10 years.
Yeah.
I seem to remember something like that. These are this is what I worry about, acral melanomas. So these are, acral means they're on the palms and soles and underneath your nails. So these are more common in Asians and in African Americans. Let's see, common like there. Usually they'll notice an oddly shaped dot either on their foot, their toe. Think about how often do you look at the bottom of your feet? Never. So a lot of times they don't get diagnosed, you know, DNA diagnosis because you don't see them. But I'm like, thank God I get pedicures often. But, so look how funky that one in between the toes. I mean, I would never see that one between my toes. But usually it would be there under the soles of the foot. Sometimes you can have them on the heel. They'll have a funky spot on their heel. So if they're Asian, come in with a new dark spot, either on their palms or on their soles of the feet, you need to worry about an acral melanoma. Okay? And this one is a subungual melanoma. These are more common in African Americans. You'll see like a nail, they call it a nail streak. So you can see it looks like a big giant. Someone painted it with a black nail polish. It's usually on the big toe or the thumb. That's where you look at those, big toe and thumb, for the subungual melanomas, where it's most common. But see, you can tell that that doesn't look right. You know, sometimes you get, does anybody get those little splinter hemorrhages in their nails from trauma? You'll ever get one of those? Looks like a little black streak. Those will grow out, you know. Subungual melanomas, they don't grow out. Or if you bruise your toe, you know, sometimes I'm like, I dropped something maybe on my toe and I'm getting my polish off, I'm like, oh my God, I don't know my toe. No, I probably, you know, as it grows out and there's nothing that comes behind it, most likely it's just local trauma. And then these are desmoplastic melanomas, so these kind of look like scars. Okay, if you look at it, the one on the right looks really kind of scarish. These are rare. But they usually involve nerve fibers because a lot of those, they're known as neurotropic melanomas, and they are very scar-like. They feel kind of like a scar, band-like on the skin. Again, most commonly on sun-exposed areas. I've seen a lot, like I've seen more on that right picture. It kind of looks like that one. But they're slowly enlarged in areas of thickened skin. So if something comes in that looks like, you know, like a scar, but it keeps getting bigger and bigger, you want to think about maybe a desmoplastic melanoma. But again, it's rare, so you may never see it unless you're working in dermatology. But these are usually pretty big, they're 6 millimeters. And they have the weird irregular borders. Isn't that funny how, I mean, look at that person's skin. They've got kind of weird looking skin in general. You know, it looks like someone who had CHF, and it's like they've got that dermis stasis on the legs, but then it just kind of sticks out, doesn't look right. So this was a patient. He had a large melanoma removed from his scalp. And we tell them not to bathe with the things on, but what do? They bathe, and they get water underneath that. So what do you think that's underneath this skin graft? Pseudomonas, probably. So then his skin graft died, but if you look closely, and he even had it on the first one, which we didn't see till he came back for his follow-up. Do you see the little black dots? Mm-hmm. He actually already had satellite lesions from his melanoma. There's that one right there, right even on the edge of his, because I don't think it was on this one. It might be hidden by a crust, but you see that satellite lesion right there? It wasn't there. And I swear this is only about a week or two. But he's got those ones down there, right here, and he's got one in front of his ear as well. So I don't know if he had those there already when they put him into surgery, or if that developed after he had the melanoma removed. But that tells you how quickly they can spread in those little, they call them satellite lesions on melanomas, those little black dots, which I'm assuming that one gentleman had. I mean, I would have called it a satellite lesion from his primary source. And this was towards the end before I left, so I don't know how he's doing. And so these are just pictures of mucosal melanomas. And there's one lady, she had one on her gingiva. It wasn't quite as drastic as that, but it turned out it was like just a very faint purple hue to her gum line. And hers ended up being a mucosal melanoma. And that one on the bottom right, I mean, the whole tongue, the whole back base of the tongue is melanoma. And this is just diagnostics, how you diagnose someone with melanoma. You can use a dermoscope, which we don't have in general clinics. Those are usually seen in dermatology clinics. But it's a little tool that it's a giant, basically, microscope, it seems like. And there's some technique when I don't remember which is which, because I can't remember now, but like if the pigment was in the crevice, you worry more about a melanoma versus on top of the crevice, if that's right. Don't quote me on that, but that's how they look with the dermoscope, because you can really see the fine lines of your skin. You basically biopsy any abnormal lesion that you suspect. Take a biopsy, and then if someone is diagnosed with the melanoma, they'll do a sentinel node biopsy to see if it's had metastases to the adjacent lymph node. In this diagnostic testing, usually if someone is diagnosed with melanoma, you can draw an LDH level, so that detects, it's not really specific to melanoma, but it detects inflammation in the heart, lungs, liver, things like that. So when our patients come back in for their yearly visit, they have to have these once a year, is we draw an LDH level, because it helps us determine if they've had any metastases. You know, if all of a sudden their LDH level goes up, you're concerned that maybe they may have a distant CT, chest, usually, chest x-ray, most of our patients get once yearly, again looking for metastases into the lungs. And then, yeah, so that's what we would do for our patients who have have melanoma. Once a year, they get an LDH and a chest x-ray. So this is what we talked about earlier, the Breslow staging. So just know that that's what they use to stage melanomas with. And again, it's looking at the depth of invasion. Again, measured in millimeters. It's the distance from the upper layer of the epidermis and the deeper portion of the tumor. And they also do TNM staging as well. But they really look with melanomas to look at how deep the melanoma goes, because that also determines how wide of your excision you need to do. So basically, the thinner the melanoma, the higher the cure rate. So I'm assuming yours were pretty thin. There was not a lot of depth of invasion. catching them early is the big thing. Standard of care is full surgical excision. Some people, depending upon their disease, if they have metastasis, obviously you have to have chemotherapy. Now they're also using biological agents along with it, with chemotherapy, just showing some improvement, so that's a biochemotherapy. But it said it helps improve the 4-year relapse rate, but not an overall effective survival. Because a lot of patients will end up stopping like the interferon just because of toxicity side effects is why they'll end up stopping it and they just stick with their chemos. Referrals, most times you refer up to an oncologist if they have distant disease. Plastic surgery, so a lot of times if the defect is pretty big, they'll want to have a surgeon close or vice versa, or depending on where it's at, you might want to go see a plastic surgeon to have them remove it. Things I've had removed from a dermatologist have never been that great as far as looking wise, because they're just about getting it out. Plastic surgeon will get it out and make it look nice when it heals. So depending upon where it is, I would go to a plastic surgeon to have them remove it. Some additional therapies, immunotherapy. That's just still under research, don't worry about that. Again, you can have Mohs like my father-in-law did. So same thing, they go in, cut around until they get negative margins, radiation, and then palliative radiation therapy for metastatic melanoma. So by the time you get stage 4, if you've had distant mets, by then it's just palliative care. There's really no cure. Like I said, in head and neck, we had very high cure rate. A 5-year survival rate is very high. If treated early, caught early. But with melanoma, it's not quite the nice statistic. Kind of already talked about the vessel depth. Median age of death is usually about 6 to 8. Highest survival seen in women less than 45 years of age at diagnosis. So melanoma metastatic is 6 to 9 months. With a 15 to 20% 5-year survival rate with current treatments. You know, and Professor Wart, her supervising physician, his wife had died of melanoma. They never found her primary. She just started having bowel issues, you know, I can't remember if she had constipation or whatnot, but she ended up having a colonoscopy, and she had tumors in her colon, and she had died, and they never did find the primary, because like again, with melanomas, they can regress. So you could have had a melanoma treated or taken out, and then years later, like that guy, that you can show up somewhere else, you know. So these are just general prevention for all your patients. So like I said, you guys will be the ones educating your patients about these things. Say, I don't want you to end up like these 60 and 70-year-old patients that I see now. So no tanning beds, you know, when you're out, wear sunscreen, protective eyewear. Because think about how many times people sit in those tanning beds without their protective eyewear because they don't want to get raccoon eyes. You know, I don't want to wear sunglasses because I'll get raccoon eyes. So just make sure that they wear protection. And then screening. So here it says screening high-risk individuals, especially males greater than 50. So at that age, you might, if you're in internal medicine, you might want to tell your patients, along with their yearly labs, that maybe they go see a dermatologist, like Paul. If he came in to see me and he was 50 and I was doing his labs, I was like, you need to go see a dermatologist at least once a year. Because at that time, he'll start getting those AKs and things like that that can be treated early to prevent them turning into sweating cells. So prevention is key, especially in internal medicine. But you guys will help your patients live a better life if you tell them to just be better. Again, teaching your patients the ABCDEs of moles, making sure they watch their moles and let you know if anything changes. Or if you see one that you're just happen to be looking at them doing some exam, you're like, oh, that mole kind of looks funny. Has it been there long, you know, and just tell them to watch it and make sure it doesn't change. So it says here, regular use of SPF 15 or higher reduces the risk of developing an SCC by 40%. And by risk of developing melanomas by 50%. So sunblock is your friend. But when we were in when I was on my rotation, I think nothing above 50 really made a difference. You know, some of those have like 75, well, it doesn't make a difference. As long as it's 50, I think you're good to go. And I always see these in my dermatologist's office, and I thought it was so funny. It is true.